Hello, I'm Dr. William Zoghbi here at Houston Methodist, Chief of Cardiology, and welcome to our cardiovascular imaging conference. Today is a very special topic. Hopefully you will enjoy the interaction and the knowledge that you will glean from all various areas of cardiovascular imaging, from echocardiography and Doppler to MRI and CT. And with me here in the studio is Dr. Dipan Shah, who is director of our cardiovascular imaging program as well as cardiac MRI, and will be also joined by Dr. Min Chang, who is the associate director of cardiac CT here at Houston Methodist. So the topic is very germane, certainly to all clinicians, in addition to imagers, because prosthetic valves are certainly very prevalent. And we see them in the echocardiography laboratory almost daily, and I'm pretty sure in all areas of cardiovascular imaging. So without further ado, I will start with the echo Doppler evaluation. Dr. Shah will address cardiac MRI, and Dr. Min Chang the role of CT in these clinical situations. So when we look at prosthetic valves, yes, we have mechanical valves, bioprosthetic valves, and the more recent, over the past 10, 15 years, catheter-based procedures, which are really very important nowadays in our overall evaluation. With Doppler, obviously, you will evaluate these prostheses through velocity and gradients. So valve size, valve type, as well as flow rate are important in these determinations, and we have to keep that in mind, particularly in low flow states or even in high flow states. Examples of different prosthetic valves, and here is pretty much to address the issue of basically pressure drop and higher velocity in mechanical bileaflet valves, where you see here the increase in velocity, and therefore the flow profile is a bit different in mechanical valves, bileaflet valves, and you will have bi-Doppler and overestimation of velocity as well as gradients, because most of the time you cannot differentiate these. However, they are already incorporated in what normal valves are in the guidelines that were published a few years ago. These were the guidelines that I was honored and privileged to chair in 2009. You will have another revision. This is under production at this stage of the game. So hopefully you will see them by next year, and an update of these prosthetic valve guidelines, including MRI and CT evaluation. Another guideline that was published a few years ago is after percutaneous valve repair or replacement, how to evaluate regurgitation. So I would invite you to make sure that you update yourself and read some of these important information. Now, what are some of the parameters in the comprehensive evaluation that I think we need clinical information? Date of valve placement, type and size of the valve, body surface area, at least to think about a prosthesis patient mismatch, symptoms related to the findings, blood pressure and heart rate. Heart rate certainly very important in valves in the mitral or the tricuspid position. Now, if you take a look at this prosthetic mechanical valve in the aortic position, if you take a look on the right side, velocity is almost 3, it's about 2.7 meters per second. Is this normal, yes or no? We take a look at the profile, the velocity, the ejection time. We take a look at all these evaluations to assess function of the valve. It's interesting here that in this very early publication, still very relevant, of a valve, St. Jude mechanical valve, we know the size of the valve, and despite knowing the type as well as size, there is a lot of heterogeneity in these normal valves of mean gradient, and that will be the same for velocity itself, which tells you also that one of the components is actually flow through the valve. So actually, if you derive an effective orifice area using the continuity equation that everybody is familiar with, the spread of these values decreases significantly because you are incorporating already the flow through these valves. So from a 19 all the way to 31 millimeter valve, Remember that because of the overestimation of velocity as well as gradients, the valve area of a 19 millimeter St. Jude valve is about 1 centimeter squared, and that could be as low as about 0.8 centimeters squared, and that's normal small valve with normal flows. So keep those in mind when you evaluate valves, knowing the size and the type of the valve that you're dealing with. Another index, which is a simplification of the continuity equation, is called the Doppler velocity index, and that has been highlighted in the guidelines. Basically, is how much did the velocity be proximal to the valve increased through the valve prosthesis. And the ratio is that of velocity in the LVO divided by the jet. And most normals are about 0.5 or so, or 0.4. But for a TAVR valve, which has a better hemodynamic profile to it, the normal is usually above 0.5 ratio, meaning that the velocity has increased twice coming from the LV outflow tract to through the prosthesis. The nice thing about this Doppler velocity index, because inherently the size of the valve relates to the size of the left ventricular outflow tract, is it is less dependent on the size of the valve that you're dealing with. And this is the same cohort that I showed you earlier for a St. Jude valve, and you could see much less dependence on the size of the valve because, again, it's a simplification of the continuity equation taking into account the size of the LV outflow tract in relation to the size of the prosthesis. Now, this is from the guideline, show you an example of a normal versus an obstructed valve. Notice few things. Velocity is much higher, certainly. Number two is that the Doppler velocity index is 0.18, which is very small. Acceleration time, which is the time that it takes from the onset of flow to the maximal velocity, increases. Normally is less than 80 milliseconds or so, and here in this obstructed valve is 180 milliseconds, giving you a more parabolic contour of the jet reminiscent of native aortic stenosis. So some of these parameters that suggest stenosis are a peak velocity greater than 4, a mean greater than 35, Doppler velocity index less than 0.25, etc., etc., in addition to a qualitative, rounded, symmetrical contour with a long acceleration time. Very important to stress that we need a post-operative study to have, it's almost like the fingerprint of a particular patient regarding to the properties of that prosthetic valve. So having a study after an intervention, either pre-discharge and ideally maybe 2 to 3 months after the hemodynamics are back to normal, that you should get a baseline study. Turning over to mitral prosthesis, we use, yes, the velocities, the E velocity, the mean gradient, the pressure half time, and effective orifice area. Remember that pressure half time was not validated for prosthetic valves, and actually in normal valves may not yield plausible values. At times they'll overestimate the actual size. Where it becomes significant is when you have this prolongation of pressure half time where it becomes meaningful. So these are the parameters that we use: maximal velocity, mean gradient, importance of heart rate. So always in your reports, make sure that you report what the heart rate is for these particular measurements: pressure half time and effective orifice area using the continuity equation. Parameters that suggest significant stenosis are peak velocity greater than 2.5, mean gradient greater than 10, effective orifice area less than 1, and certainly a long pressure half time. However, there are limitations of pressure half time if you have merging of the ENA, if they're still in sinus rhythm, the issues of LV compliance, atrioventricular coupling, and significant aortic insufficiency that would affect it. Notice that we have not talked at all about transesophageal echocardiography. And I think the importance of TEE is when you have non-diagnostic or borderline cases by transthoracic echo, assessment of concomitant regurgitation, particularly in the mitral position, patients with known severe obstruction, if there are candidates for thrombolysis, to assess the mechanism of obstruction as well as the size of thrombus. The TE visualization in a mitral position is almost 100%, is actually the first time when we use TEE that we could see the valve itself, its ring, if there are any issues with opening and closing of the prosthesis. These are the mechanical prosthesis. In the aortic position, since you're imaging tangential as opposed to en face, much problematic to be able to see well the opening and closing of these leaflets. Therefore, practically maybe 20-30% of the time that you could see nicely, and you could say with confidence whether the prosthetic valve opens well or does not open well. That's why I think in mechanical aortic valves, fluoroscopy or radiology procedures are more of a favorite, and I think you may see that in the guidelines coming up. So either with fluoroscopy to take a look at the angulation, or nowadays with CT scan. I know Dr. Chang will talk about that. Notice that in the obstruction here, that you could see one of the leaflets that is frozen. The other one is actually, you can see a thrombus in it. So if the patient has renal dysfunction, you may just use the CT without dye to take a look at opening and closing of the valve. And if you want to look at the mechanism of whether there is a thrombus and how large it is, you're going to use most likely contrast dye to do that. Regurgitation, mechanical valves have usually some built-in physiologic regurgitation. A classic for a bileaflet valve that you could see here is a tri-jet, very small, doesn't penetrate much in the left atrium if they're in the atrial position. And Starr-Edwards, we don't see as much anymore in these valves. Notice also that for echo Doppler, for both imaging as well as flow, you may have shadowing and flow masking. It happens much less in the aortic position, obviously, because you could see the jet either in the parasternal or in the apical views, as opposed to in the mitral position, particularly in mechanical valves, where you could have shadowing and masking, and therefore the flow masking occurs also in Doppler interrogation. And this is such an example here. Just imagine for yourself whether you're going to be able to see regurgitation itself and how much regurgitation occurs in this patient. In the same patient, notice that there is a major dehiscence of this prosthetic valve and very large regurgitation that can be easily missed by transthoracic examination, particularly in mechanical valves in the mitral position. So the clues from the transthoracic examination for significant MR in mechanical valves are a high E velocity greater than 1.9, high mean gradient, and high is relative, meaning you're not going to look at 10 millimeters or more gradient, usually 5, 6, 7. It's really not that elevated. An elevated Doppler velocity index, which is the ratio of VTIs greater than 2.2, a good LV function but low systemic output in the pulmonic or the aortic position, pulmonary hypertension, TER velocity greater than 3. Now, in the aortic position, an easier way to assess regurgitation, just like we talked about, because you have much less flow masking we use the same criteria, if you will, very similar criteria to native aortic regurgitation, keeping in mind that there are a lot of incidents of eccentric jets because of perivalvular regurgitation that occurs predominantly in mechanical prosthesis. So we look at pressure half-time. Remember, this is indirect measurement of severity and much more dependent on hemodynamics. We try to do regurgitant volume and regurgitant fractions, and importantly, diastolic retrograde flow in the aorta per se. So take a look at this example here. You have significant regurgitation, and also at the same time, you could see a small aneurysmal display in the parasternal window and maybe an early abscess formation in this prosthetic valve in the aortic position. Now, certainly we've evolved significantly over the past decade or so in the world of catheter-based interventions. That's something that we didn't really dream about. This year is actually the 20th anniversary of the first TAVR by Alain Cribier. But we've evolved also in putting edge-to-edge repair in the mitral position, in the tricuspid position. So these are the guidelines that we published about 3 years ago from the American Society of Echocardiography, addressing catheter-based interventions, but predominantly not flow through them, but the regurgitation or remnant of regurgitation. Take a look at this TAVR valve. How severe is the regurgitation? You know, after implantation of these valves, you may have punctate regurgitation in different areas, different from what you do in a surgical replacement. Also, at times, the severity is much higher in a certain angulation. So for you in the long axis view, for you to be able to see this, you have to go almost off axis to be able to see the regurgitation. You can have very eccentric regurgitation, depending on the origin of where the serpiginous flow that occurs and after implanting such a valve. In the catheterization laboratory, you probably would need more than just color Doppler unless it's very obvious. People use hemodynamics, use angiography at times to take a look at aortic regurgitation and the severity, and put all these together to decide whether to do further interventions on such a valve. After the patient is out from the catheterization laboratory, imaging such a remnant regurgitation or new onset regurgitation may be difficult. And remember that these valves are rather long. The valve itself may occur at this level here, so you have to have a nice sweep and scan, because if you image just further below the valve, you will overestimate what the regurgitation is, and you have to be really at the site of where regurgitation is. People talk about circumferential extent as well as the vena contracta area. I think both are important, and the reason for it is at times the vena contracta area may be quite delineated in a certain area and can be the same severity as one thinner but longer one with a much longer or larger percent circumferential extent. So keep those in mind. A good sweep from the short axis to take a look at the valve and identify where the areas of regurgitation is. Take a look at the vena contracta area as well as the extent of regurgitation. And this is the algorithm that we proposed about 3 years ago in the guidelines. We're not going to go through it here. There are a few differences between native and these prosthetic valves, particularly in the vena contracta and circumferential area. And we don't mention the size of the ventricle and its function, because many of these are rather acute or subacute, and the ventricle would not dilate in those situations. For a mitral clip or basically edge-to-edge repair of these valves and the mitral position, the residual regurgitation can be quite challenging, actually. It could have different forms, so it could be challenging from a color Doppler point of view. Vena contracta is also very important in these situations, and you can add vena contractas that are important. What you look for is a significant reduction in the color Doppler, of the color Doppler extent as well as vena contracta. You also look for almost normality of the pulmonary venous flow, which was reversal here before, and then almost the resurrection of the systolic wave, higher systemic output from the transgastric window, and actually more spontaneous contrast in the left atrial appendage. In the outpatient setting, after TEER, basically there are some extremes that you may see, but here this is one extreme. It looks very mild. You really don't need anything else. The jet is very mild. The mitral inflow is also A-dominant. Pulmonary venous flow is fine. When it gets a little more significant, it becomes problematic to be able to measure it using PISA, because PISA is really not advised in those situations except qualitatively, and you may need further quantitation. And the quantitation, if you want to do quantitation, you use contrast so you don't underestimate the size of the ventricle and its stroke volume, and compare it to a systemic output either in the LV outflow tract or pulmonic. And not infrequently, you may need a transesophageal echocardiogram or use an MRI, just like Dr. Shah will tell you, to quantitate the significance of the regurgitation, regurgitant volume, and regurgitant fraction, if that is important in your overall decision. And this is the algorithm that was proposed for evaluation of residual mitral regurgitation after a TEER procedure. So in conclusion and in summary for you, from an echo Doppler point of view, clinical evaluation, know what valve type and size you're dealing with. And remember, echocardiography is the first line in evaluation and in follow-up of patients with prosthetic valves or interventions on the valve. A baseline echo Doppler study after surgery is really mandatory because these patients, will be living in such a condition, and not infrequently they may get into issues, and you may need to compare the baseline echocardiogram with subsequent studies. Transthoracic 2D Doppler evaluation of structure and function is indeed the first-line diagnostic method. In cases with high velocity jets and gradients and suspected stenosis or regurgitation, compare previous studies. Use X-ray, either fluoroscopy or CT for mechanical aortic valves, and for TEE for all the other conditions. And certainly CMR, just like Dr. Shah will show us in some cases where prosthetic valve regurgitation is also important to quantitate if you're not confident with what you're seeing on a transthoracic examination. So I will turn it over to Dr. Shah to tell us about the role of CMR in prosthetic valves.
Okay, thank you, Dr. Zoghbi. And let me go to my slides here, and we'll just touch on the role of CMR for prosthetic valves. I think the first thing, this is a question I probably have once a month people ask me is, are prosthetic valves safe to undergo MRI? Because obviously we know we want to be careful with any metallic objects because of the potential risks with MRI. The good news is most of the valves that we utilize today have been tested up to about 4.7 Tesla, and the magnitude of the force that's applied by a magnetic field is not sufficient enough to cause any dislodgement of the valve. So really the answer to this question is all of the valves that we utilize today at clinical field strengths of 1.5 and 3 Tesla, which is what all cardiac imaging is done at, there's not a concern per se with mechanical valves. So the next question really is, how do you use MRI in prosthetic stenosis, prosthetic regurgitation, and then we'll touch a little bit about prosthetic valve endocarditis. So the first thing to keep in mind, one is we talked about safety, but the other, I think, important thing is talk about the artifact that you get. And so mechanical valves in general, metallic valves, are going to give you a pretty significant amount of artifact. So if you're trying to assess for stenosis, it can be quite challenging by MRI. And so as a result, my answer would be that if it's a mechanical valve and your question is about stenotic severity, MRI is probably not the best test to do that. Now for bioprosthetic valves, and this is a nice publication from a few years ago from a group out in Europe, where they looked at patients with a variety of different biologic prostheses, and you can see that the amount of artifact is variable depending upon different prostheses, but in general, for most of the bioprosthetic valves, the artifact is fairly manageable, and so when it comes to assessment of stenotic severity, it oftentimes can be done with MRI. And I'll go through and show you an example of one study which looked at this, and this was from one of our former fellows here, which looked at a series of patients, nearly 100, with bioprosthetic valves, and the goal was to try to assess anatomic orifice area as well as effective orifice area by MRI and compare that to echocardiography. And so the strategy that was taken here was to essentially do a phase contrast at the level of the valve itself and then compare that to a reference area either in the LVOT or distal to the valve, and then use a methodology analogous to what's used in echocardiography, where you're where you're basing it on the principle of conservation of flow, and essentially come up with a kind of a time velocity integral at the valve prosthesis itself, a time velocity integral at a location either subvalvular or supravalvular, and then measuring the area of the reference region, supravalvular or subvalvular, and using that to compute a effective orifice area. And in this study, you can see the relationship between the values derived by MRI and the values derived by echocardiography actually was fairly strong, really suggesting that, in fact, for patients with bioprosthetic valves, when there's a question of valve area assessment, there is a role for MRI in this application. Let's move on to valvular regurgitation, because really this is the area I think probably where MRI has the greatest strength. And I'm going to go back again to kind of the basic methodology that we use for native valves. And for the aortic valve, the approach that we would generally take is to directly measure flow above the aortic valve leaflets, as is shown in this example here. And from this methodology, determine what the forward flow is, as well as determine what the retrograde flow is, and use that to determine regurgitant severity. Now, with bioprosthetic or mechanical prosthesis, you may have to modify the approach a little bit. Here's an example of a patient with a transcatheter prosthesis, and there's a couple of different approaches that we can take here. One would be to try to measure the direct reverse flow, but obviously you don't want to be at the leaflets, because you can see the artifact that we have from the transcatheter valve. And so as a result, you want to be a little bit more distal so that you're beyond the area of the metallic artifact. And using this methodology, we can measure the direct reverse flow. In this case, we get about 45 mLs for this patient who's about 6 weeks post-transcatheter aortic valve. But really the method that I prefer to use for these cases is actually to measure the forward flow proximal to the valve, so basically measured in the left ventricular outflow tract. From that tells you the total flow coming across this LVOT. You can compare that to the flow coming across the pulmonary artery, and then the excess flow that you have in the LVOT compared to the pulmonary artery or the systemic flow would represent your aortic regurgitation, which in this case measured out to be about 50 milliliters. And then obviously you want to use some of the confirmatory checks that we have, one of which is looking at LV remodeling. The other is measuring flow reversal in the descending aorta. And the nice thing here is there's no issue of metallic artifact that you need to worry about. And in this example case here, visually you can see that it does look like there's flow reversal in the descending aorta, but we can actually go through and measure it, and we can actually quantify the amount. And what we see really is that there's more than 10 cc's of holodiastolic flow reversal. And again, we know from our studies in native aortic regurgitation that this can be also a marker that's fairly specific for having 3 to 4 plus aortic regurgitation. And this patient, on the basis of these findings, then went on, was taken back to the cath lab, and you can see here on the aortogram really evidence of 3 to 4 plus aortic regurgitation of this transcatheter prosthesis. This patient had a redo of the transcatheter prosthesis with significant improvement in his symptoms and did well clinically afterward. In fact, there's a nice study that came out of a Canadian group looking at patients with transcatheter aortic valve regurgitation, and it really found a few things. One is that for those patients who had a transcatheter regurgitant fraction of more than 30%, that was associated with worse all-cause mortality as well as worse composite of mortality and heart failure rehospitalization. Obviously, I think that the numerical threshold is a little bit lower because they noticed a worse outcome at really a regurgitant fraction of more than 30%. And there could probably be a couple of reasons for that. One is that this is, in some ways, in these ventricles that were aortic stenosis ventricles that are typically very hypertrophied and stiff ventricles, this may be analogous to an acute form of aortic regurgitation where they went from no aortic regurgitation to all of a sudden having a significant aortic regurgitation load. Obviously, in the setting of a small underlying a cavity that was more of an aortic stenosis ventricle, it's likely not able to tolerate even small regurgitant volume loads. And again, that's why in this series they noticed that regurgitant fraction was much better predictor of clinical outcomes than regurgitant volume itself. Let's turn to the mitral valve, and really, this can be a scenario where you have a patient who had a mitral valve repair, as is shown in this example here, who has residual regurgitation, or a patient who had a mitral valve prosthetic replacement, as is shown in the right-hand side. And what's the way that we would try to determine severity of regurgitation for a case like this? Really, it's going back to the same methodology that we use for native valves, which is this indirect method of comparing the left ventricular stroke volume to the aortic outflow. And the nice thing, again, here is that despite whatever the prosthesis artifact that you get, the ability to assess left ventricular stroke volume is really not impaired. And so we'll go back to this one example case here where you can see it looks like there's a dehiscence and there's a septal jet of mitral regurgitation that you see. When we measure the stroke volume in this patient by just standard planimetry, there's 157 ml of left ventricular stroke volume, but compare that to the flow coming out of the aorta or the left ventricular outflow tract, which is only 82 mLs, suggesting a significant difference, and that difference is what we would attribute to the mitral regurgitation, which in this patient is 75 mLs and associated with really severe mitral regurgitation. One of the advantages, obviously, in addition to assessing the severity, is we're also able to look at the LV remodeling, and you can see here, not only are we getting severe regurgitation, we're getting confirmation of that by the fact that you have a very large LV end diastolic volume, well above what you would expect for a patient of this size in BSA. Let's move now to endocarditis and what, if any, role is there for cardiac MRI in the evaluation of endocarditis. Well, I think if you're trying to identify the presence of vegetation, in this case we can see one, but oftentimes recognize, since the MRI technique is done over several cardiac cycles, if you have a randomly mobile vegetation, you may not be able to see it. And certainly if you have mechanical valve leaflets which cause localized artifact, you may miss a vegetation. And so as a result, I would say really there's really no role for CMR in trying to identify if there is a vegetation present or not. However, if you have a patient who has known endocarditis and you're looking for the complications of the endocarditis, be it regurgitation or be it communications, abscesses and dehiscences, that's where I think MRI could be useful. So let me kind of wrap up with kind of the final concluding slides before I turn it over to Dr. Chang. I think one is that CMR is not optimal for identification of vegetations on prosthetic valves, and really for mechanical valves or transcatheter valves, if the question is stenotic severity, CMR is not optimal for that. But I think it is useful if you're trying to assess bioprosthetic valve stenosis, and I think it's most useful is going to be if you're trying to assess regurgitation of either mechanical, bioprosthetic, or transcatheter valves. And with that, I will pause. Thank you for your attention, and we'll turn the floor over now to Dr. Min Chang. Min, can you, I see you're there. If you want to just share your screen and talk to us about the role of cardiac CT in prosthetic valves.
Say it one more time, because I'm not sure if you hear us.
Okay, Min, we're going to turn the floor over to you now. If you want to share your screen.
Yes.
Wonderful. If you want to share your screen, the floor is yours, and you can talk to us about the role of cardiac CT in assessment of prosthetic valves.
All right, let me share my screen. So can someone enable me to do the screen sharing? Can the host?
Yes, sir.
Okay, our AV group, I think, is working on it right now.
Thank you.
And while we're waiting for that, Bill, let me pose a question to you. So, one of the questions is for transcatheter valve regurgitation. Again, these are mainly aortic stenosis ventricles. I know the guidelines typically talk about severe as 60 cc's. What are your thoughts on that? Should we be looking at fraction more? Should we use other markers?
I think the early data said that even a mild regurgitation, affects outcome. I think the more recent data questions that the mild ones would really affect outcome significantly. But certainly if you're moderate and above, the ventricle could be very sensitive to a volume load where the baseline ventricle is usually small and less compliant. So I think moderate and above should be of concern from an overall symptoms point of view, maybe prognosis point of view, in a population that is very sensitive conceivably to a volume load situation. So going back to your question, should we use regurgitant volume or regurgitant fraction? Always use them together. At least tells you about what the volume load is in addition to the volume fraction load. So whenever the total output of the ventricle is normal or less, regurgitant fraction is going to be a little bit more emphasized than the actual regurgitant volume. The converse is true also. If you have a large ventricle and with a regurgitant volume or 60 or 70 or 80, the regurgitant fraction may not be above 50% or 60%. So I think they should go together for us to be able to make a determination. But I think moderate and above should raise concern from an overall outcomes point of view. Okay, so Min, looks like we see your slides.
Yes, can you hear me?
Yes, we can hear you.
Yep.
Can you hear me?
Yes, we can hear you just fine, Sumin.
Okay, I'm going to get started. Okay, there's been tremendous advances in CT, the role of CT for management of prosthetic valve. So I'm going to spend for the next 15, 20 minutes a quick overview of what CT can do, because for more detailed discussion, I need to spend at least an hour. So this is the type of valve that we most commonly encounter in our CT lab. I always tell my fellow that by the time you can tell the size and type of valve by looking at the CT scan, you're ready to go out and practice. So on the left-hand side is bioprosthetic valve, mechanical valve, and other type of mechanical valve. Those actually are still being put in, but more and more, this is the type of prosthetic valve, which is transcatheter-based valve. These are the one who's going to dominate our the type of valve that we see in our CT lab. Okay, I'm not going to spend too much time. The main advantage of CTA is compared to TE, for instance, is less artifacts, especially for aortic valve position, and also provide better understanding of anatomical relationship between other part of the cardiovascular structure. But the key disadvantage, this is very important, is very limited in functional information, if any. So CT will never be the first test of choice for evaluation of patient suspected prosthetic valve dysfunction. It has to have at least transthoracic echo first before you consider a CT as part of your workup. So this is what I think the most important role of CT for both diagnosis and pre-procedural planning. I think we're still doing a lot of diagnosis part, but more and more, the CT reader, our role is mostly going to be shifting toward procedural planning, because most of the patient, by the time they arrive at a lab, they probably already have a diagnosis. Occasionally, CT can help pinpoint a little bit better where the dysfunction comes from, but most of the time, our role will be telling our interventional or surgeon, provide them the information about the valve and the roadmap. Real quickly, this is the most common one of those most common causes of the obstructive lesion in the aortic valve, which is inflammatory response to the prosthesis, causing soft tissue growth or pannus. This is a very dramatic case, one of the worst case we've seen. Pannus underneath, usually underneath the annulus and the ring, okay, in the LVOT side with low density, but not as low as clot, for instance. So not only bioprosthetic valve can give you pannus, mechanical valve can also give you. This is one example of it. It's a patient who has very high gradient, underwent redo, and this is a surgical specimen, and this essentially those are fibrotic inflammatory tissue. Okay. So other important part of the assessment of mechanical prosthetic valve is opening angle and closing angle. So this is just a case of a normal opening, a normal opening and closing of the valve angle. And let's see a case of a normal CTA. So patient with coming with elderly lady coming with heart failure symptom. Okay. Not sure why it's not playing. Okay, there we go. So in the CT, you can see there is several area of low density with Hounsfield unit around 50 and 70, very consistent with clot. Okay, and you can see actually there is one component which is supravalvular, and the other one was subvalvular. So this is a 3D rendering of the soft tissue, which most likely represent clot. Patient underwent heparin infusion with persistent elevated gradient. Then she got TPA, significant improvement with the gradient and symptom, as you can see right here. And the follow-up CT, okay, it's not playing, fortunately. You can see there is persistent of that tissue underneath the prosthesis valve, but the patient, despite incomplete resolution of the abnormality, patient was doing much better. So this is one case. Okay, none of my videos are playing. All right. Okay, this is a case of bioprosthetic valve with the mass, obviously very low density, and this is surgical specimen show that it was a clot rather than endocarditis. This is called courtesy of one of our colleagues from Siemens. So how do we differentiate obstructive prosthetic valve lesion by pannus versus clot? This is not that different from what we learned from TEE. The time frame is a little bit different, but importantly, the Hounsfield unit and the location. Usually, clot has lower Hounsfield unit, and pannus has higher Hounsfield unit, and the location usually is mostly supravalvular, and pannus usually subvalvular. Not only mitral or aortic valve could have problem, there's more and more patients that we see with tricuspid valve abnormality. This is a case with very severely degenerated tricuspid prosthetic valve with significant stenosis. How about regurgitation lesion? Regurgitation lesion, the main role of CT is not so much in diagnosis, because TEE is a lot more sensitive in picking up regurgitation lesion with a color Doppler. And CT suffer from decreased temporal resolution. And so every time you see what you think of paravalvular leak or regurgitation lesion, you always have to confirm by looking at the TEE to make sure what you're seeing is not an artifact. So this is just some dramatic cases of patient with severe dehiscence and paravalvular leak, okay? an aortic position, and this is a mitral position. The most common type of transvalvular AI will be degenerated changes of bioprosthetic valve of the calcium and tear and causing flare leaflet and transvalvular eccentric AI. Endocarditis, obviously, this is TE is much more sensitive in picking up endocarditis, but we use CT in patient. We suspect complication from endocarditis as fistula, such in this case, a patient with prosthetic valve, aortic valve, the mass in the underneath the leaflet, and appears to be causing fistula between the LVOT and the right ventricle. As you can see here, there's a passage of contrast during systole and non-muscular diastole, and this was confirmed during the surgery. This is another case, a patient with prior mechanical prosthetic valve. This is before the patient, after the surgery, very nice low gradient. And this is when the patient presented with fever and heart failure symptom. As you can see here, this is cases of prosthetic mitral valve endocarditis. Okay, so now let's switch focus on the transcatheter valve. So the most common type of valve, there's two for aortic valve position. This is the balloon expanded valve or sapien valve. Essentially, it's a stainless steel frame with bovine pericardial leaflet. I'm sorry, there's an alloy frame and bovine pericardial leaflet. That's sapien. As you can see, this is placed almost exactly the same level where the aortic valve would be. Okay, so this is the leaflet. This is a little bit higher. Okay, so this is. And this is what we call self-expanding valve. Okay, as you can see right here, this is before the procedure, and you can see after the procedure, all this calcium is being pushed, and this is at the level of the leaflet. You can see again, all this doesn't go away once you deploy the valve. All this gets pushed down pushed aside between the prosthesis and the aortic wall. As you can see right here, the leaflet is actually supravalvular in relationship to the native aortic annulus, for instance, right here. Okay. So what kind of abnormality this transcatheter valve can have? Just like any bioprosthetic valve, they could have degeneration, as you can see right here, severe calcification, thickening, maybe some clot. Okay. But most commonly commented and well-known entity, which we're still studying a lot, is what we call hypoattenuated leaflet thickening and restrictive leaflet motion, which this was published several years ago in the England Journal paper, and we still figuring out what does this really mean and if anything needs to be done with it. But essentially, when we look at the CT, what we need to report is the thickness of the leaflet and to see if there's any hypoattenuating material, and how in coronal sagittal view, what percentage of the coronary sinus is being filled by that type of material. So this is kind of standardized, the different grade, so we can better understand the clinical significance of this entity. This is just an example of some mild, a little bit, this is maybe a little bit mild to moderate. And obviously, you don't want to have this severe, involving all three leaflet. And believe it or not, patient has some heart failure symptom, and after heparin infusion and anticoagulation, the gradient, and oral anticoagulant, the gradient improves significantly. Some patient is not as lucky. This is a lady who also has severe degree of Hall thrombosis, was in cardiogenic shock, very high gradient, and it's a surgical specimen when she was went to the OR and got explanted. The PVL for a TAVR valve is a lot more difficult because there's no ring, there's no reference like surgical place valve that we can find the leak is. So in order for you to diagnose paravalvular leak, you really need to find a column, continuous column of contrast connecting the aorta and the LVOT outside the prosthetic valve. This is a case of a patient with very eccentric paravalvular leak. CT give you some more idea of what could have caused this paravalvular leak, most likely due to incomplete expansion and decreased apposition due to the presence of a very large calcific deposit. Okay, this is one of the other very unusual complication. It's a lady who came back with heart failure symptom, and essentially most likely explanation was patient ended up having a VSD, likely the frame, metallic frame of the prosthesis eroded through the interventricular septum, causing the VSD. Okay, so for procedural planning, I think I spend more time doing procedural planning right now when I read a CT, and we talk about PVL closure with CT fluoral fusion. Basically, we would need to provide to our interventional cardiology the location and size. This is all in conjunction with a TEE, but this has become less and less common. We haven't done that recently, too many cases. But what we're doing a lot is what we call valve-in-valve planning. Essentially, patient have a failed bioprosthetic valve and high risk for redo surgery. So the surgeon or intervention cardiology will try to deploy a new transcatheter valve in there. So this is a quick case, a patient with bioprosthetic valve. Bioprosthetic valve, this is a type of valve. You have to give them diameter, and then basically you can deploy a virtual valve and look at the relationship between the coronary ostium and the virtual valve, and anything less than 6 millimeter we consider high risk, right? So this case was all good, is very good. The RCA was actually supra prosthetic, so it's about the bioprosthetic valve, so that's safe. This will be a case of high risk for coronary obstruction because the major risk of this procedure is causing coronary obstruction. So this is what it looks like after a patient has already have a TAVR and have a valve-in-valve putting. And one thing we're doing a lot also planning for TMVR valve in ring. So here we need to provide with our interventional guys, the ring size and the likelihood of LVOT obstruction, like right here. This is a case that's a very favorable anatomy, and this is what it looks like, a sapien valve deployed in the mitral valve position. And in some cases, this is just some miscellaneous cases. For instance, this would be a case with very unfavorable anatomy because a very thick septum, small cavity, the angle between the aorta, aortic root and mitral annulus is almost perpendicular. So causing, this will be a high risk for LVOT obstruction. So this is something that your interventional guy need to know before they do the procedure. And but more and more we'll be seeing cases like this, patient with TAVR with mitral clips. So this is kind of what we'll be looking at right now if you want to interested in doing cardiac CT. Okay, and this is the new transcatheter mitral valve that we'll be working. And the last, I think briefly, if the patient have clinically suspected prosthetic valve dysfunction, you always do the echo first. Obstruction lesion, I think CT offer very good value in figuring out what type of pathology is causing obstruction. Regurgitation, not so much. Endocarditis, less. And so for regurgitation lesion, endocarditis, the key for CT is to plan for reintervention. Okay, that's all I have. Happy to take any question.
Very good. Thank you, Sumin, really for a great overview of what CT can offer. And I think we've covered echo, MRI, and CT, right? Yeah. Maybe I have a question for you, Dr. Chang.
Sure.
What can we know from CT if we do not do angiography? And I'm saying that question because at times you have patients with advanced renal dysfunction, and the question is, can we tell motion? What can we tell if we look at a prosthetic valve, be it bioprosthetic or mechanical?
Thank you. That's a very good question, Dr. Zoghbi. I think one thing we can do without contrast would be for the opening angle and closing angle, same thing the interventional cardiology used to do when they do the fluoroscopy. So for opening angle and closing angle of mechanical bileaflet valve, you don't need contrast. The other thing that I try to show here that I think I did not spend enough time is if patient has bioprosthetic valve and you plan for valve in valve, as I show you, let me go show it right here. You don't need to have right here. You don't need to have contrast study because you can see the strut. Obviously, if it's a stainless valve, out of luck, but most of the valve ascended, we can see the top of the bioprosthetic valve, and we can see the coronary takeoff even without contrast. Most patients, even without contrast, you can always see the origin of the. So I would say for mechanical valve to look at the opening and closing angle, and for bioprosthetic valve, aortic position, valve in valve, non-contrast CT could be used if you definitely cannot give contrast.
I mean, this is very informative because I think, we will see patients with such and make a decision, still end up with a diagnosis as to, because quite a bit of, I really think if you don't have a previous echocardiogram on a patient, and there's always a question of prosthesis-patient mismatch, and you want to take a look in mechanical prosthesis, whether you have a small valve, the size of the valve, and its motion. I think it's very good to be able to do that.
Yeah.
If you have any questions, please send them to us. You could do that by POLEV, as you know by now. Enter DeBakey or text DeBakey to 37607. A question for you, Dipan. Biological valve as opposed to mechanical. How much artifact do you have from the ring itself? Does it impair seeing the leaflets, and are there maybe any sequences that you would do to decrease that artifact?
Yeah, no, that's a great question. So for the biologic valves, there is a spectrum depending upon the amount of metal within the struts and then just the construct of the valve itself. I would say that most of the biologic valves, the amount of artifact that we get is really not that much, that you can still try to perimeter the valve leaflet openings, but there's some where the amount of artifact is much more. So I think when it comes to stenosis assessment, it's going to be if it's a mechanical, you're out of luck. If it's a bioprosthetic, probably 3/4 of the time, you're able to visualize the leaflets pretty well without artifact from the metal, so you can get an assessment. And then obviously for regurgitation, since you're doing that at a location separate from the valve itself, regurgitation assessment's not impaired by the metallic artifact.
Very good. All right. Well, appreciate your joining us today. to evaluate prosthetic valves and its various functions. I know we talked a little bit about endocarditis, but I know we have covered this in the past few weeks. So I would encourage you to take a look at that and see the value of each one of the imaging modality in endocarditis. And we look forward to seeing you next week. Have a good day.
All right. Bye-bye.
Bye.